the outset, I'm going to thank Rajeev for giving me the opportunity. I'm going to just give you an overview of how different imaging modalities are going to help us in diagnosing or managing macular diseases better. So let's look at what are the imaging modalities we have. So one is fundus photography is one thing which we commonly use just to document, and sometimes you want to set and analyze a fundus retina of a patient. You might have to take a fundus photograph and sit and look at finer details of it. You might not get that much time to keep looking at the fundus when the patient is in front of you. The next thing is fundus fluorescein angiography. So fluorescein angiography has been there for quite some time. If you look at the picture there, you can in the patient where you have multiple brucine, and many times you are not able to clearly differentiate whether there is any small area of subretinal fluid in those patients. And where it's out, you might even get an OCT. You see a multiple brucine, which is a brucinoid PED clearly seen, and there is no subretinal fluid. You're reasonably safe that you can clearly observe this patient. You don't have to keep doing angiogram in these patients routinely. So, and some case where you have an asteroid halosis, so you're not able to look at the macula that clearly, and you see asteroid bodies like this. Anyway, this is an example of a case where you had doubt of an etiology. What is that which you are looking at? If you look at the OCT carefully, there are a few dot-like hyperreflective spots seen in the posterior vitreous cells, and there is a vitreous cells which are there. Gives you information about most probably inflammatory etiology which you are dealing with. So looking at an OCT gives you idea about what's happening to the vitreomacular interface, and look at this, there's a complete posterior vitreous detachment there, and what's happening here is the attachment of the vitreous to the macula causing the CME. If you look at this clinically, you might see there's a CME, you don't know what's the reason. To do an OCT, you might be able to identify there is a vitreomacular traction which is causing the CME there. And there is a more obvious traction which is seen here. Epiretinal membranes, you can identify early epiretinal membranes like this coagulation which is seen there in OCT. And look at in the pseudo hole which where you have increasing thickness of the retina, and you see the other layers are still intact there. We have an obvious macular tractions. The macular edema OCT has been definitely useful tool in differentiating what types of macular edema and what exactly may be the reason for the macular edema. So if you look at this, there's a diffuse macular edema which is seen here in this patient. You see a focal edema in this and in the area there. And you have a diffuse edema with an epiretinal membrane which is there tightly at the hand, which is causing diffuse macular edema in this patient, which might not be useful in doing an anti-VEGF injection. And the OCT can be used to follow up many of these CMVM patients where you look at the retina and look at the intraretinal fluid and treat these patients, whether you look at the subretinal fluid or intraretinal fluid, and try to see the activity of the disease and then treat those patients. The macular holes is useful to identify whether it is a pseudo hole or a true hole. That you look at this, that you always look at the tissue there in the center, whether you have all the layers of retina seen in the center, that means it's a pseudo hole. If you don't see any of this, you see the loss of tissue, then it tells you that it's a lamellar hole or a lamellar hole in the outer layers, or you have a full thickness hole where there is a loss of tissue all through and through. That's a complete macular hole. You can even look at OCT, looking at what layers of the retina got involved. You might be able to identify which type of disease you're dealing with an AMD or a certain nerve fiber layer loss. You're dealing with something like an optic nerve disease. And that toxicity, like this is a chloroquine toxicity where you see an early changes where there is an outer layer loss which is seen. That's an earliest change which we might be able to pick it up with an OCT. So you look at the OCT here, it gives you a CME, and you have an OCT, and you will have an OCT which gives you a CME, and you don't have to keep repeating this angiogram every time, and you might look at the OCT and try to manage this patient. So you may have to combine both investigations together sometimes. In ICG, one of the main indications is something like a patient like this. You see orange elevations. Do an ICG, you'll see a clear-cut polyp seen everywhere. So that's one disease where ICG is one of the main indications for identifying polyps in the choroid. This is a patient where we have choroidal granulomas. You can look at the choroidal OCT where you can actually see a loss of choroidal architecture there, and you see an elevation there in that area. They have subretinal fluid along with it. So that's a patient where we have an angiogram. There is not much leak there except the diffuse leak around in this area. The autofluorescence is that's what we usually see. So this is not actually an angiogram. This is an autofluorescence where there is an increased hyperautofluorescence in this area. Try looking at CSR leaks. Don't see much early RP changes. We see a hypoautofluorescence and sometimes some hyperautofluorescence sometimes. So do a chronic CSR, you see a diffuse RP atrophy, which is more obvious even in autofluorescence. And more the autofluorescence makes it more obvious in cases of dry AMD. Autofluorescence is definitely useful in early detection of macular telangiectasia. You don't have to do an angiogram in all these patients. You might do an autofluorescence, you might see an early loss of that central hypoautofluorescence in macular telangiectasia. And the doppler exclusion, you will get nice hyperautofluorescence. So, in conclusion, basically there are multiple investigative modalities which we have, and it's useful in diagnosing many diseases and following up of many diseases. But the combination of these investigations is more important, and clinical correlation is definitely what is needed. But no one imaging modality is going to replace the other one. It's going to be a combination of all these which is going to help us. That's what is going to be. Thanks.
That's good. Rajeev, any one particular